This video showcases the management of a case of progressive vitreoretinopathy in von Hippel-Lindau disease. VHL is a rare autosomal dominantly inherited multisystemic neoplastic condition caused by mutation in the tumor suppressor gene VHL. One of the hallmark manifestations of this disease is the presence of retinal hemangioblastomas, which are vascular hematomas found in approximately 49 to 60% of the VHL patient. These RH tend to be bilateral, multiple, and typically situated in the temporal periphery of the retina. Age of diagnosis typically occur during early adulthood. Small RH may remain asymptomatic for years. Untreated lesions often progress with ages and can lead to blindness in approximately 10 to 15% of the cases. Nevertheless, there have been a few reported instances of spontaneous regression. VHL-related ocular complication includes exudative or tractional retinal detachments, epiretinal membrane, macular edema, uveitis, complicated cataract, neovascular glaucoma, or vitreous hemorrhage. Due to potential for multisystemic neoplasm, managing VHL necessitates a multidisciplinary approach. Early detection, intervention, and consistent surveillance are the crucial aspects of VHL management. At our hospital, 21-year-old female patient presented with a 1-week history of defective vision and floater in her right eye. She had no previous systemic illness or family history of similar condition. Upon examination, her best corrected visual acuity in right eye was 636 and in left eye it was 66. Anterior segment evaluation and intraocular pressure for both the eyes were unremarkable. On fundus examination, there was a small vitreous hemorrhage inferiorly. Large retinal angiomas were noted in superior temporal and temporal quadrant and were supplied by dilated and tortuous feeder vessels. Superior temporal angioma displayed an elongated structure projecting into the vitreous cavity and extending up to the oris aorta, creating a distinct dumbbell-shaped appearance. These angiomas were enveloped by compacted vitreous contracture band, and they were responsible for causing vitreomacular traction at the fovea. Additionally, a few smaller angiomas were also observed in the infranasal quadrant. Optical coherence tomography scan revealed an altered focal contour, primarily due to the presence of epiretinal membrane and vitreomacular traction, which were quite evident. Fundus fluorescent angiography was performed for both the eyes to delineate all the angioma's lesions. Left eye fundus evaluation also showed multiple small angiomas lesions, which were well delineated on fundus fluorescent angiography. Based on identification of bilateral multiple retinal hemangioblastoma, a diagnosis of von Hippel-Lindau disease was established. Furthermore, in the right eye, there was additional finding of an epiretinal membrane along with vitreomacular traction. The patient underwent comprehensive evaluation to detect any systemic manifestations related to VHL disease, and no such manifestations were identified. Additionally, it was recommended that genetic testing be conducted for both patient and her 3-year-old son, along with ongoing screening for any potential VHL-related condition. Both eye underwent treatment with thermal laser photocoagulation. The right eye required a total of 3 sessions, each 1 month apart, while the left eye was successfully treated in single session. 3 months following the laser treatment, the patient's right eye BCVA declined from 636 to 5/16. On fundus examination, it was observed that the RH had displayed signs of regression characterized by decrease in size, redness, and vascularity of the RH, and normalization of their caliper and reduction in the toxicity of the feeder vessels. However, there was worsening of the vitreoretinopathy leading to increase in epiretinal membrane and vitreomacular traction, which ultimately resulted in further decrease in BCVA. The worsening of the vitreoretinopathy can also be visualized on OCT. The BCVA in the left eye remained at 6/6, and retinal hemangioblastoma showed signs of regression. Given the patient's progressive vitreoretinopathy, deterioration of macular traction, and decline in visual acuity, the decision was made to proceed with a surgical intervention. The treatment plan involved partial vitrectomy in combination with epiretinal membrane peeling, internal limiting membrane peeling, and endophotocoagulation to the RH. Intra-op surgical video displays proliferative vitreoretinopathy along the RH. Following core vitrectomy, a delicate dissection of the vitreous contracture band was performed to separate them from the RH. Special attention was given to ensure the removal of all vitreous adhesion from the RH, as any residual vitreous can lead to development of proliferative vitreoretinopathy at later stage. Further, some measures were taken to prevent any significant bleed from the RH during the procedure. Thick ERM was peeled. This was followed by ILM peeling. Line of photocoagulation was done to all the RH, and the case was closed under the air. 4 months after the surgery, there was noticeable improvement in patient's right eye BCVA, which increased to 618 from 5 by 60. On fundus evaluation, it was observed that all retinal hemangioblastoma had regressed, and the caliber of the feeder vessel had returned to normal. Additionally, there was sign of oval starting to normalize and stabilize, which can be seen on OCT as well. This case highlights the potential for the exacerbation of epiretinal membrane and fibrovascular proliferation following laser photocoagulation for the retinal hemangioblastoma. In such scenario, pars plana vitrectomy can be an effective treatment option. It is essential to emphasize the importance of regular follow-up and surveillance to monitor for the recurrence of RH and systemic manifestation.